attending. We're so excited to be here. The American Kidney Fund, our briefing today. We're kicking off National Minority Health Month here on Capitol Hill with a very important subject, which is kidney disease in minority communities. We've got a really great line of speakers, and we will look at this issue through the lens of policy, the lens of patients and caregivers, the lens of community efforts to decrease the burden of this disease, and through the lens of promising developments in research. So we will save some time at the end for questions and answers, but without further ado, I'd like to introduce the President and CEO of the American Kidney Fund, Varn Burke.
Thank you, Holly, and thanks to all of you for coming out this morning to discuss this very important topic with us. You know, it's amazing. The Centers for Disease Control say there are over 30 million people in this country at some stage of kidney disease, and yet most of them don't really know it. This is a very impactful disease in our country. It is the 9th leading cause of death. It actually kills more people than breast cancer, prostate cancer, and automobile accidents when you look at all phases, all stages of kidney disease. 96% of the people who are in the early stages of kidney disease don't know it. Just almost 50% of those who are in advanced stages, almost ready for dialysis or transplant, still don't know it. Most folks find out that they are in kidney failure, they go to the emergency room, and they have something that might feel like and look like flu, only to be told that they immediately need to go across the street and enter the hospital dialysis program. One very important goal of the American Kidney Fund is to make sure that those folks who are at such a high risk know it before they get to that point, and that they get the care that they need, hopefully to slow down the progression, hopefully to prevent the disease from happening in the first place, and certainly if they are in kidney failure and are going to have to go on dialysis or have a transplant. We want to make sure that from a clinical perspective, they are as ready as possible, that they understand their options, that they have the pre-care that they need to have so that they can have the best outcome from what may become their dialysis or a transplant regimen. We're going to talk today especially about how this disease impacts minority communities. But we also want to share with you what the American Kidney Fund is doing and has been doing for almost a half century now to deal with this disease. To make sure that those who are at risk understand not only their risk, but understand that there are things that they can do to prevent the disease, to slow down its progression, or to ensure that when they go into dialysis or transplant care, they are from a clinical perspective as prepared as they possibly can be to get the outcomes. And when they enter that stage of needing dialysis or transplantation, the American Kidney Fund is there again to help them access the care they need by helping them pay insurance premiums and get other kinds of services that their insurance may not cover. The American Kidney Fund is focused on all stages of kidney disease. Throughout this country, every year, we're screening and educating millions of people about the risk of this disease and what they can do if they are at risk or if they have it. We are also, through our many programs, educating people about the factors that make them, the family relationships, the ethnicity, that make them at higher risk. We're partnering with national and local organizations so that we are able to extend the impact, the reach that the American Kidney Fund has directly through many other thousands and hundreds of thousands of people throughout the country. Today, we bring to Washington, D.C. our ambassadors who will help us spread that word and to talk about their story to make policymakers more aware of what it's like to live with kidney disease or live with a family member who has kidney disease or who indeed may be in kidney failure. We're learning a lot through all of our efforts, and we're analyzing the data that we're able to collect through these efforts to improve how impactful we can be and the information that we can share with others. Today, we are very honored to have a long-time member of the kidney community and supporter of the American Kidney Fund to speak with us. Former Congresswoman Donna Christensen has been a leader with regard to health care with a particular focus on access for minorities, both in her time in Congress and throughout her career. She also has been many firsts. She was the first female medical doctor to join the U.S. Congress. She served on many committees where her experience, both from a policy perspective and as a practitioner, were very, very impactful. For 16 years, she was chair of the Congressional Black Caucus Health Brain Trust. She was very much involved in the development of the Affordable Care Act, especially the equity provisions. And we're very happy to say that she has recently extended herself to another first. She is the first member or former member of Congress to join the board of directors for the American Kidney Fund, and we're delighted to have my one slide. Good morning, everyone. It's great to see so many of you here for this really very important briefing this morning. I'm honored to be here with this outstanding panel that you'll hear from some great friends and former colleagues in health that I've seen for a long time, and of course with all of the patients, caregivers, and advocates, and it's always great to be back on the Hill. So as you've heard, I'm not only here as a member of the Board of Trustees of the American Kidney Fund, where I serve with some very committed and distinguished people, supported by a hardworking, dedicated, and effective executive team and staff. But I speak to you today also as a family physician who practiced for over 21 years in a community that's mostly Black and Hispanic, high poverty rates, median income well below the national, and rife with social and economic determinants that were adverse to health. In fact, the need to change the environment in which my community struggled to be healthy was the impetus for me running for Congress, and I still work on those issues today. But walk into any dialysis center, anywhere, even in those communities where there are few people of color, and I'm sure you'll see a disproportionate number of people of color. There are about 30 million people in the U.S. with kidney disease at some level, and as you've heard, too many of those with mild to moderate changes when we can stop or slow the progression have no clue. African Americans are the most disproportionately impacted. We're 13% of the population, with 35% of patients on dialysis. But Latino Americans with kidney failure or end-stage renal disease have also increased over 70% since the year 2000. And Native Americans and Alaskan Natives are 1.2 times more likely to have end-stage renal disease. And why? We've always focused on the risk caused by the high prevalences of diabetes and hypertension. And well, we should, because together they're at the root of about 3/4 of all of the chronic kidney disease and end-stage renal disease that we see. And it's no surprise that minorities are the most impacted because African Americans are twice as likely as non-Hispanic whites to have diabetes, and 40% of African Americans have high blood pressure or hypertension. 1 in 10 Hispanics have diabetes, and 1 in 4 has high blood pressure. Native Americans and Alaskan Natives also have high rates of diabetes. But these are not the only important factors that increase one's risk. Research supports that if many of these individuals with hypertension, diabetes, or even early chronic kidney disease lived in different communities where there was equity and the social and economic conditions supported healthier lifestyles, these disparities would increase. The disparities in kidney diseases and every other will never be successfully reduced or eliminated if the lives and living conditions of those who are so disproportionately impacted are not transformed significantly. This has been and continues to be the focus of the Congressional Tri-Caucus ever since it was formed, from the first Health Equity and Accountability Act to the one introduced late last year. We got as many of the provisions from that act into the ACA as we could, but there's still a lot more that needs to be done. And much of that is with the social, economic, and environmental determinants of health. So, I have my one slide up there. The increase in chronic kidney disease and end-stage renal disease are not just a national issue. not just here in the US, it's of global concern. This slide is actually from a Canadian study and lists some of the determinants that create the disparities in kidney disease. But being a different country, perhaps they did not have to include, as we do here, racism and discrimination, both inside and outside of the healthcare system, as well as segregation, unequal educational system, and the resultant stresses of hundreds of years that are shown to impact even the neurophysiology and genetics of the African American population. And it can affect other communities of color as well, and particularly the American Indian, the Native, Alaskan, and Hawaiians, and those of us who live in the territories. Here on the Hill, so let's talk about what we can do. Here on the Hill, we look forward to the reintroduction of the Chronic Kidney Disease Improvement Research and Treatment Act and the reintroduction of the Health Equity and Accountability Act in this Congress. And since every Congress it gets better, we expect that kidney disease will now also be included under Title VII, and we ask you to advocate for that as we meet with the members today. Under Title VII, which addresses high-impact minority diseases. We also expect that Republicans, Democrats, and Independents will come together to make sure that millions of Americans don't lose their insurance coverage or protections. So the main message of these brief remarks is that to stem this unsustainable tide of kidney disease, which costs our country billions of dollars every year, we need all hands on deck. Not only those in the health committees of Energy and Commerce or Ways and Means, but on education and labor, on independent agencies, on financial services, on agriculture with its utility services, telemedicine, as well as its economic development programs, small business, and all of the others, including appropriations and armed services. In fact, DOD has lots of research dollars, and Congress has directed DOD, as well as some other agencies, to improve research and development infrastructure and increase R&D at HBCUs and other minority-serving institutions, and that's something we need to make sure happens. Lastly, don't forget to share this information that you hear today with your family and friends. Again, thank you for coming, and on behalf of the trustees and everyone in AKF, we look forward to working with you, your members, and your committees on a comprehensive effort, not just to eliminate the disparities, but to reduce kidney disease at all levels and in every community in this country. Thanks.
Thank you so much, Congresswoman, for continuing to work on these really important issues to this community. I realized when I started the program today, I forgot to introduce myself. I just want to say I'm Holly Bodie, the Vice President of Government Affairs at the American Kidney Fund. And LeVarn said that, pointed out all the people in blue shirts. These are all our amazing advocates. We do a fly-in every year around this time. So we have an incredible group of people. So if you see someone in a blue shirt, please introduce yourself. They're here to talk about their experience with kidney disease and what it means to have that affect yourself or your family or someone you care about. So our next speaker is well known for her work as a former Deputy Director of the Office of Women's Health at the Department of Health and Human Services. But what she's not as well known for is her amazing and dedicated role as a caregiver for her daughter who is living with kidney failure. She is also an AKF ambassador. She's wearing a blue shirt, and she's a model for patient and caregiver empowerment. So we'd like to welcome Frances Ashburn.
It is exciting to be back in Washington, D.C. from South Carolina. But it's sad for me because every time I talk about the story, I remember the 29 years with my daughter. And she's still alive, okay? You see, my daughter, Cheryl, was diagnosed with kidney failure at the tender age of 17. It has been a long, hard fought journey ever since. Just put yourself in my place and imagine that as a registered nurse, you are always a firm believer in annual medical checkups. You take your daughter to the doctor, Her blood pressure was 220 over 110. Very scary high. My daughter was getting an annual physical as she was on her way to college and needed this medical information. The doctor immediately started testing to determine what was the underlying cause for this hypertension. They gave her medicines and we were sent home. My daughter did not think this was a problem because she was going to the bathroom less often, so she had more time to do her other stuff. She was a busy teenager. Just 2 weeks later, I got the call to take her to the ICU immediately. She was diagnosed with kidney disease. What? Who? Not my child, was my confused reaction. How could this be? Not my child. While in the hospital, there were many specialists, many medications, many treatments. Even as a care provider, I was still unsure about what all they were doing and stayed in constant contact with the internet to keep up with the various treatments and medications. However, only with the credible sources at NIH. Over the years on hemodialysis, she had 2 cadaver transplants. However, both of them failed. She even had one removed due to sepsis. She had so many conditions. You would be amazed that she's still here, and so are her doctors. Just let me name a few. Cardiac tamponade, many pneumonias, many AV grafts, fistulas for dialysis. She had a heart attack in 2010. She's had stents, she's had filters, she's had seizures, she's had bilateral paralysis, carpal tunnel syndrome, retroperitoneal bleeding, pleural effusion, blood clots in her lungs, abdominal atresia, neuropathy, bilateral fractured hips, superior vena cava syndrome, acute respiratory insufficiency, sepsis, peripheral edema, C2, C3, spinal stenosis with cord compression, amyloidosis, interstitial lung disease, Augustine antibody, and many, many more. She wants another transplant. However, she has been turned down by the Medical University of South Carolina, Duke University Hospital, and Augusta Transplant Center due to her medical complications. This is so sad. She says that it's not her fault that she must endure all these conditions. Yet 29 years later, she's still very positive about living her best life. Throughout her illness, I taught her to know everything about her medicines, procedures, lab tests, and doctors. I gave her a steno pad to write down everything that happened, who said what to her if I was not there. She looks up to her doctors on Google to find out what their practice is, what their specialty is, what their scores are. She is an heroic advocate, not just for herself, but for other clients in the dialysis center. I am here today to specifically ask all of you to join in the efforts to create better outcomes for people with kidney disease. Those that are currently seeking a better life through advanced treatments, through transplants, and through living donor programs. It may be too late for my daughter for another transplant, but it's not too late for others. I sincerely thank you for your presence here today, and remember to get your annual physical also. Thank you.
Thank you so much, Francis. You're truly an inspiration. We really appreciate your participating today. So we have a special guest with us. Congressman Donald Payne from New Jersey is here to give a couple of remarks. He has had his own journey with kidney disease, and so I'm happy to turn it over to him, and thank you for coming.
to be here with you this morning. Before I get into my remarks, let me acknowledge former member of Congress who is here. I'm sure she was introduced, but she was a great friend to my father and myself. My father was a member prior to me for many years, and 23 years. And she was always a partner with him on health-related issues. So it's good to see Congresswoman Donna Christensen. From the Virgin Islands. I mean, you gotta be a member of Congress. It's not a bad stint, you know. You know, some members don't go home as much as they should, but Ms. Christensen always went home. There's a reason to go home, you know, but it's so good to see her, and she's been a great support of me since I arrived. Well, let's see, where do I start? Well, I just left dialysis and came right here. I started in January. I've been kind of hovering around 20% kidney function for quite some time, so the doctors were kind of up and down on when I would do it. I didn't want to do it at all, and obviously, and we all probably been there at some point in time. But the thing about it is, now I'm upset that I didn't do it earlier, because I feel twice as good that I have not felt this good in 40 years. And you know, and then the old man kind of kicked in. I said, well, let's see, the kidneys are at 20%, 20 from 100 is 80. So 80% of the garbage that needs to get out is still in your body, basically. So, you know, rudimentary math kind of helps you realize where you are. But I've been a true fighter of, you know, in dialysis Monday, Wednesday, Friday, and but I'm paying attention on how, you know, the procedures in the dialysis center, how the patients are treated, and you know, what they're going through. We really need to continue, as it sure says, to empower people with kidney disease. I did not realize the depth of the problem across this country and the need for kidneys for so many people. And so, I mean, I'm living it, so you got me, I'm with you. So I just wanted to come by, and I'm very excited about this. And I was so excited about coming here that last night, when we were making plans, I forgot I had dialysis. I wanted to come here, and my chief of staff reminded me, oh, yeah, don't forget, you have to go. I said, oh, yeah. But we got over here, and just consider me. I see that my district is number 16 in the country. So we're in this fight together, and I want you to know that you definitely, and all of those members I know, understand what we need to do. So thank you very much. God bless you, and let's keep fighting. Thank you.
Thank you so much, Congressman Payne. We really, really appreciate your coming by. It means a lot to us. So now I'm here to introduce our next speakers. We've heard a lot about how important efforts around education and prevention are to change the trajectory of kidney disease. Our next speakers are showing that community-based initiatives can also have a huge impact on people's lives. The co-directors of the Gaston and Porter Health Improvement Center, Drs. Marilyn Gaston and Gail Porter, have both spent their careers trying to improve the emotional and physical health of children, adults, and families, especially those who are poor, minority, and underserved. They're here today to tell us about how they are transforming lives through their Primetime Sister Circle program. So please welcome Drs. Gaston and Porter.
So we're always so glad to see somebody who knows how to do this.
Good morning, first of all.
And we're just delighted to be with you to talk about our program, the Primetime Sister Circles. African American women, of whom there are over 9 million in midlife, we're defining midlife as between 40 to 75, are very diverse in terms of our education levels, our incomes, our interests, our religious beliefs and practices. But unfortunately, there is one thing we share.
And that is our health. We want to talk for just a minute around the magnitude of the problem. And the previous speakers were just so eloquent in how they outlined the magnitude of the problem. But we want to talk about it from the Black women's health perspective. So first of all, this is showing all women in the United States, and as everybody else in the United States, the top 3 causes of death are heart disease, cancer, and stroke. The red bars are us, as African Americans. And you can see we're dying at rates greater than any other group of women in this nation, from heart disease, cancer, stroke, and diabetes, and as you heard, also from kidney failure. The red bars are us. Yellow bars are white women, green, Latino, gray, Native American, and blue are Asian. This also impacts on our life expectancy. When we look at all the women in the country, we're at the bottom in terms of how long we live. And you need to know, I was surprised when I saw the data from CDC, that the disparities, the differences in life expectancy, or the gaps, are the biggest here in the district. Bigger than any place in the country. It's a frightening thing. Because some of our women, some of the richest people in the country, the most knowledgeable, etc. But we are trying to address issues of hypertension. As many of you know, hypertension, as you heard earlier, hypertension is heavy with our kidneys. And you can see, again, the red bars are us, the disparities. The left is the United States, in the middle is Maryland, the data, and then DC. Look at the disparities in DC between Black women, white women, and Hispanic women. The green bar is bad. Also with diabetes, you can see the disparities there with us. Diabetes, but also breast cancer with the kidneys. There are major risk factors for chronic renal disease. Obesity, look at the disparities. We are the biggest women in this country, and in many ways, the biggest women throughout the world are right here in terms of Black women. And chronic disease, just to show you again the disparities, and this is both men and women. But we wanted you to see it, but you heard this painted, the previous 2 speakers were painted.
But it's not only our physical health that we're dealing with. And we now know that depression in particular has a major impact on all of these chronic illnesses. And unfortunately, many of us don't know the symptoms of depression. And/or in our community, we are quite apt to wear buttons that say, "I'm too blessed to be stressed." And as I had to tell a sister once in CVS, who was a cashier snapping at everybody, I give a lecture called, "I'm too stressed to know how blessed I am." And we want you to join our Primetime Sister Circle.
So the prior magnitude of the problem of the data is to stress and stress you.
That's right.
Are you depressed? That was the bad news. And here's the good news, because we have an intervention called Primetime Sister Circles that's focused again on Black women between the ages of 40 and 75. This is a picture of one of our circles, and you can see that they are having a fall. And we aim not only to educate, to really give them strategies. People know what to do. The question is how. And, you know, as a physician, I have to tell you, we don't do a good job of educating people. We're so busy trying to see the problem, treat the problem, get them out. But we don't talk to them about the problem or how to deal with it. But anyway, the prime time sister circles consist of about 25 to 30 Black women ages 4 to 75. They're all community-based. They don't come to us in the office. We go to them wherever they are. We're in the churches with them, we're in the rec centers with them, we're in the community public housing with them, everywhere. And it's important because it really helps them to begin to get to our services, first of all, and also to have a staff that's culturally competent. And we also address the levels of health literacy. That's another thing that our healthcare system, by the way, Dr. Porter is a psychologist. I wanted you to know that. Anyway, our healthcare system does not address all the levels of health literacy. And many of our women come in and you'd be surprised at the percentage that can't read at the ages of 4 and 75. And so that's very important for them if we're going to educate them and change their behavior. The period that they're seeing 13 weeks, 2 hours a week. And we have facilitators, 2 facilitators run the programs, and we also have experts to come in and to show them how. Nutritionists, dietitians, and it's evidence-based. They don't learn anything unless it has definitely been proven by research. The program helps women to, number one, prioritize their health. Now, you know if you're married, but you know your mother and your grandmother. And you know they didn't take care of themselves first. I tell them, you're so busy taking care of Lottie and everybody that you cannot put yourself on your to-do list. So one of the first things they have to learn is how to prioritize themselves. We help them to get their blood pressure in control, to practice stress management, increase their physical activity, and improve nutrition. The resource book is a book we've written. Of course, in the rush of it, we forgot to bring it to show it to you. But anyway, it's focused on really not only educating, but giving women skills. As I said, they have to know the how. How do you really practice a daily life of prevention? See, we also need to focus, and I'm sure the people is focused on also prevention. So our PTSD, you just know we're fighting prevention. So we don't want our hypertension to not be controlled, because if they remain under control, they're certainly going to be under control. We have a curriculum designed by professionals, 2 facilitators, and the experts in fitness, stress management, nutrition, and hypertension.
But no matter how good a program is, it's the results that make the difference. We published 3 articles in the Journal of the National Medical Association. This was the results of a survey that was funded by the Kaiser, Permanente, and Walmart. We now have over 3,000 women in 7 states and DC who have gone through our program, and as we indicated, it's totally free. And what we've seen, the pre is the red, the post is yellow. When women come in, they do not want to claim a right to take care of themselves first. But by the time they leave, they're wearing sweatshirts or t-shirts saying, stand behind me, I'm taking care of me first, then you. Learn stress management techniques that are deep breathing, things that they can do no matter what their level of income. Nutrition, really teaching women how to control our portion size. As one sister said, you know, Dr. Porter, my pastor is saving my soul in the sanctuary, but my body is being killed in the fellowship hall. And she went to talk to them, and they changed that. Reducing salt and exercise. But most of all for us, it's the level of satisfaction that the women have. Almost 100% of the women love the program, their knowledge and skill levels. And one thing we're particularly excited about is the curriculum is so focused on being able to provide service. We had a sister who lives in public housing say to us that maybe if she had had materials like we provided, she could have graduated from high school.
And I'm gonna just show you one of the clinical results that we did. Well, no, here are two. The first is weight loss. 68% of the women lost weight, which we're really proud of because we are not a weight loss program, we're a holistic program. So we deal with prevention that's focused on physical health, emotional health, and spiritual health. That's 68%. Some of the women within the 3-month period of time lost as much as 20 and 25 pounds. So we're very happy with that. Now look at this in terms of hypertension. That's really one, again, I hope everybody, because people do not know that if their hypertension remains under control, they're going to get kidney failure. If their diabetes is not controlled, they're going to get kidney failure. And we had to shout this, everybody has to have this message. I get on the elevator. And I said, you know what? She does. No, I do. I really do. I mean, they're standing there, what they're doing, that's an opportunity. You know, we all have these elevator speeches that roll, even elevators and youth. So anyway, hypertension, 52% of our women are hypertensive. When they enter, their hypertension is out of control. Some of these people have, some of the women have already been in, they are in a primary care program. They have been diagnosed and they are on treatment. But their blood pressure, they walk through the door, the systolic blood pressure of 200 and non-systolic pressure of 100. Just to show you the magnitude of the problem. Okay? When they enter, 52% are hypertensive, but when they leave after 3 months, down to 22% are not. That are hypertension.
And finally, the return on investment, because if you're going to go to funders, and our program is totally funded by nonprofits, foundations, and others, they want to know, are the dollars worth the investment? And we're pleased to say we had our program evaluated by Dr. Daryl Hopkins, who is the director of the Johns Hopkins Center for Health Disparities, and Dr. Patrick Richard, who is the director of research prevention for uniformed services. What they found that the return on investment for each dollar spent in the first year ranges from almost $3 to almost $8. For 3 years, it ranges from almost $10 to almost $23. It includes hypertension, diabetes, and mental health status, and health improvements translate into medical care costs and improved working productivity. We want to end this the way that we did for the women. I'm going to do that, the fact that, because we forgot our book, the last chapter in our book is called Reaching the North Star. And this is a poem by Becky Bertha that our participants have told makes such a difference. We normally read it together, but because Dr. Gaston can't find her glasses, I'll read it. She'll come in, but our secretary had to send it. But anyways, I said, this poem is one we always read, and it goes. There will come a day, it is not far off now, when you wake in the morning and know that you were meant to be happy, and that you wanted and healthy, and that you wanted more than you want things or memories, any concrete place called home, all the strings of the past that fasten you, more than you want justice or pride, your old play image of yourself, or the faint chance that all that has gone wrong may still change. It is you who hold the power to change, and whatever it is that holds you, whatever it is you think you cannot live without, the time has come to open your hands and let it go. Run, flee, disappear, break loose, take wing, fly by night, move like a meteor, be gone. If you fear it will never be possible, think of Harriet Tubman, who traveled alone the first time, who finally freed 300 people, but first had to free herself. There's a Harriet in all of us, and we must take the opportunity to finally free her. And thank you so much.
Wow, that was amazing. Thank you so much. Thank you. That's just great. Thank you. So this much is clear, that tackling the problem of kidney disease in minority communities is a multi-pronged approach. One of those approaches is research. Kidney disease research has traditionally been underfunded compared to other diseases, and as a result, very little has changed in the treatment of kidney disease since the late 1960s. But there is hope on the horizon. Some of that hope comes from genetic research to better understand why African Americans have kidney failure at more than 3 times the rate of Caucasians. Our next speaker, Patrick G., calls himself the voice for the voiceless and the face of the faceless in the fight against kidney disease. He's a minister, an AKF ambassador, and a member of the steering committee for an important genetics research initiative that he is here to tell us about. So please welcome Mr. Patrick G.
Good morning.
Good morning.
Good morning.
Good morning.
Let church say amen.
Amen.
There's some good talking up in here. Thank you, ladies. I don't know how to do it. Just to share a little bit about my story very briefly, I am going to be 2 years into my kidney transplant on the 21st of this month. My kidney journey began in April 2013. Again, I got transplanted April 21st of 2017. I woke up from surgery, the kidney did not. 5 days later, I had a blood clot in my neck, had to get an operation on that. 3 days after that, I was bleeding internally. So I had to have another surgery. They installed a J2 that looked like a hand grenade, had that for 17 days. Ended up getting a 4th surgery so that they could create a heart on one side. 4 surgeries, 33 days in the hospital. The kidney did not wake up until the 47th day. And I have been boots on the ground ever since. It is an honor to be standing in front of my peers, those that are known as kidney warriors. I thank those that are living donors, Congress. Thank you for being a living example on Capitol Hill that you're still able to fight for the people and to work for your constituents all at the same time that you battle kidney disease. So we really want to thank you for that. I have the honor and pleasure of being a member of the Apollo Steering Committee Community Advisory Council. And the Apollo study is the study of the APO1 genotype. Now, I don't know about you, but I know that diabetes is the #1 leading cause. Hypertension is #2. Nobody in my community had ever told me about a genetic predisposition. So when I was asked to be on this committee, I felt that this was a way for me to be able to be on the cutting edge, to be able to help my community and to share this information. So just to give you a little bit of history on the APO1 genotype, this is a gene that mutated 10,000 years ago. This gene was discovered in the western part of Africa from the people, the Yoruba people of Nigeria are most prominent with that. So it affects many African Americans whose ancestry can be traced to this particular group of people. Now, here's a very interesting thing about this gene. The way the APO1 gene works, they had to understand how sickle cell works. So, if you know anything about sickle cell, one variant of sickle cell can prevent malaria. 2 variants of sickle cell, you will actually get sickle cell disease. Well, with the APO1, one variant, and a variant, you get one variant from your mother, one variant from your father. So it doesn't make a difference which one of those variants that you have, but with the APO1 genotype, one variant prevents African sleeping sickness. Two variants put you at risk for renal failure. So one of the things that the Apollo steering committee wanted to do, this is an observational study. And recently, they noticed that African Americans that received a kidney from another African American living donor or deceased donor, they know that the kidney would reject quicker than if they received it from a non-African American. So basically what this study is, and as you can see on the chart, is broken down with three forms. You see G0, G1, and G2. G represents genes. So everything is fine if it's a G0 or G1 or G0 and a G2, but it still can put you at risk for being a carrier. It's when you see a G1 and G2 or G1 and G1 and G2 and a G2 that puts you at risk. And even though you may have two variants of it, it doesn't necessarily mean that you're going to be at risk. They found out that 13% of African Americans actually have two variants, but it doesn't necessarily cause renal failure. So one of the things that APO1 is attributed to is FSGS, also HIV attributed end-stage kidney disease, as well as hypertension associated end-stage kidney disease. So this particular gene is what's known as a non-diabetic risk variant. So of course, with diabetes being the number one cause of kidney disease, they wouldn't even look at that. Or even if a person was at risk of having that, it would be more associated with those folks that may have lost their kidneys by way of hypertension. So today, I just wanted to make sure that before you leave, please get a handout to understand this, because one of the important roles of being a community advisory council member is because there was concern, and this research study was put together through the National Institute of Health, as well as Wake Forest University. It's led by Dr. Barry Friedman. He's the lead investigator on this. But one of the interesting things was when we first got together as a council, and the council is made up of 26 people from around the United States. The first thing that came up was the Tuskegee experiment. The second thing that came up was about Henrietta Lacks. And then all these different medical atrocities that African Americans have been involved with, they came up. So it was our charge to ensure that the integrity and the professionalism and the accuracy of this study would be carried out. So one of the interesting things, the first day that we actually were invited to the meeting, everybody that had a medical acronym behind their name was asked to lead the table. And all of the patients, family members, the living donors, and care partners was asked to have a seat at the round table. And that set the precedence to, because a lot of people talk about patient engagement and patient-centered focus, but this is the first time that I've actually seen it in action. So it was just an honor, and this is a 5-year study. Study should kick off in mid-spring, and at the end of the 5 years, we hope to be able to have a better understanding of how this gene affects African Americans in regards to renal failure. And I would believe that after that, it would allow us to be able to sit down and come up with a comprehensive and innovative method of being able to seek a solution. Because hearing numbers that was brought up at our last meeting a couple of weeks ago, when it talk about less than 500 African Americans were living alone in 2018, and that's very disparaging. So maybe if we can find a cure for this, then maybe more people of color will be willing to donate. And again, in talking about people of African descent, we're talking about Africans, African Americans, Afro-Hispanics, and Afro-Caribbean. So it's covering the whole gamut. But again, I really want to thank you all, and just please take care of your health, take care of your kidneys, and when you go to your physician, don't be afraid to ask them about genetic testing, because it may not be for you, but it's for those that are coming behind you. So I just want to say thank you very much.
Thank you so much, Patrick. We really appreciate all of your work on the Apollo project, but also for being a great advocate for AKF. We're really proud to have you as part of our ambassadors. So our final speaker is Dr. Sandeep Patel, who is currently the Open Innovation Manager at HHS, helping HHS develop prizes, crowdsourcing, accelerators, and other open innovation tools to spur innovation in healthcare. He is leading the new HHS Kidney Innovation Accelerator, also known as KidneyX. We heard HHS Secretary Alex Azar talk about KidneyX last month, and so we're really excited to have Dr. Patel here tell us a little bit more about it. So thank you.
Thank you. It is an honor and a privilege to be here. Okay. So thanks to the American Kidney Fund and to the ambassadors for raising the volume on the issues around kidney disease, in particular the disparities associated with it. I, by the way, did not get the memo on blues that happened to work today, so it worked out really well. Cool. So I want to tell you a little bit of a story on what we're trying to do to spur innovation in the prevention, treatment, and diagnosis of kidney disease broadly at HHS. You all have heard the stats, you know the stats, you live the stats, but I just want to emphasize one point that dialysis, when it was invented, was a medical breakthrough at the time. We were in a position to extend people's lives that otherwise couldn't, but it has not changed substantially in the decades since it was invented. And it looks very much the same as it did decades ago. And again, you've seen the stats, but I want to emphasize a couple things. One is that 13 people die every day waiting for a kidney transplant. It's an issue that, if it's not urgent, should be urgent in people's minds. And that's one of the things that we're trying to change with KidneyX. So some of you might be thinking, based on today and what you know, message received, public health crisis. Surely, because we're the United States of America and we live in the greatest innovation ecosystem in the history of mankind, that there are smart people working on a solution to this. And my answer to you is not really, but we're trying to change that. Let me see. So, and so if the patient burden, the public health issue isn't enough, well, at least it's very expensive to treat. The cost to Medicare is substantial. We pay about the budget of NIH, or entire biomedical research budget, to treat and save renal disease. About 7% of Medicare and about 1% of the entire federal budget. So this is an issue no matter how you look at it. And the answer to whether there are smart people working on this, I think is exemplified by the fact that if you look at investors in healthcare, this is a space where there are more and more investors putting in money towards better therapies, better solutions for people. But if you look, and you can't really see it, but if you look at the breakdown by disease, kidney disease, renal does not show up on the radar. This is not something that investors are paying attention to. This is not something that the world at large is paying attention to. And again, this is something we want to change. And there's a bunch of issues in here, but I want to just point to one thing in terms of why there isn't innovation in kidney disease. And I think we've fallen into what I would call the good enough syndrome. I think we're at a stage where people think it's good enough the way we treat those with kidney failure, those with chronic kidney disease. We have dialysis, we have transplants, and we've developed an entire healthcare infrastructure, payment, delivery, culture around treating with dialysis and transplants, and it's led to some of the issues that you've heard about. And I think there's three ways to tackle this. So one is just from a financial perspective. There isn't enough money to go around for smart ideas. There isn't enough money to support entrepreneurs, innovators, people on the ground with good ideas who want to develop them for patients. Whether that's early stage research money, or whether that's developing and supporting clinical trials, whether that's further down commercialization. We need to create pathways for good ideas to see them through. And I think the only way to do that is to find ways to share risk between government, industry, and nonprofit foundations. The other is around perception, right? What we want to do is change the conversation from a sense of despair and acceptance to one of hope and possibility. And the third is around policy. We, as HHS, have roles as funders, as market regulators, as payers through Medicare. And we want to create clearer pathways for entrepreneurs and innovators to navigate those complex processes, so good ideas can see their way through. And we want to demand innovation. I think we have to get to a place, and we're getting there, of not accepting the status quo, but demanding something better. So this was sort of the background to creating KidneyX, which we did in partnership with the American Society of Nephrology. And the idea is really to do the first two things on here, which is one, offer funding opportunities through a series of prize competitions where we're addressing patient originated unmet needs and supporting innovators from a broad swath of perspectives and backgrounds in the development of solutions to those. The second is to improve coordination across HHS. So I mentioned, we're a research funder, we're a regulator, we're a payer, and I think we have to find better ways of working together to support, support entrepreneurs and work on behalf of patients in a more coherent way. And I think we do the first two. Our real goal here is to de-risk commercialization, to unlock more money, to make this a place where people find that they want to put their money into, that they want to support good ideas, that so we can encourage more shots on goal, we can test more ideas, and we can get things to solutions to patients faster. And really, all this is to create a sense of urgency on behalf of people living with kidney diseases. It's not an issue that people often associate with urgency, but when people start dialysis, they're on a different clock. And we have to recognize that, and we have to realize that, in order to support and help them, this is an issue that is time-bound and urgent, and we have to act quickly. And I'll describe KidneyX in a little bit, but when we sat together and started this, we came up with a set of principles. So we're very much a startup culture. We wanted to do something a little bit different than what had been done before to unlock innovation and medical product development. But we set and agreed on a set of principles, and no matter where we went, we would adhere to these. And I won't go through these, but I want to hit the first one, which is that we want to be patient-driven as much as possible. Not just patient-centered, but patient-driven, right? We want to start with the needs of patients and find ways to address that. But then along the way, we've incorporated patient input into our entire process. And I'll describe that in a little bit. Our partnership with the American Society of Nephrology. So this makes sense from a number of perspectives. Our goal is to share risk, pool money together, take advantage of the roles that we play as HHS and government, and the roles that ASN plays with their networks and their expertise in nephrology and understanding of the space. So our first piece of KidneyX that we launched late last year is a prize competition that we call Redesign Dialysis. So this is where we're asking for ideas on paper and prototypes of new ways to reimagine dialysis to address kidney failure. I should say that this is coupled with another effort, another partnership that exists between American Society of Nephrology and the FDA, which is called the Kidney Health Initiative. And one of the things that they did was they mapped out all of the scientific and engineering problems that need to be solved or addressed to get us to a next generation of treating kidney failure. And the four sort of things that they laid out was to improve significantly dialysis as it is, but also to think about how do we develop portable, wearable dialyzers? How do we think about developing implantable devices, like we have with other parts of the body? And then how do we support and sort of unlock the idea of regenerated kidneys, where, and these are approaches that are on the map, and the roadmap lays out the different ways that we can bring a broad community together to address them. And one of the big pieces of this, I should mention, this is a $2.6 million prize that was broken down into two phases. So one is the first one that just ended is an idea phase, where we asked for ideas on paper. And the second phase, which is going to commence soon to the end of the year, is a building and prototype phase. And layered on top of this roadmap and in KidneyX is very much part of everything is the patient quality of life issue. So, in consultation with patients, these features were laid out as if any new technology or product that's developed has to incorporate these as features in order to significantly improve patient quality of life. So in our first prize, the idea again is to build this community, to start spurring innovation, bringing experts together with clinicians on the ground, with patients, with other people, and to start generating and testing new ideas. The first prize we're going to give out $75,000 apiece to about 15 submissions. We just closed the submissions and made the judging process, and we're going to announce the winners at a summit we're hosting here in DC, April 29th and 30th. And so I'm just going to plug this in because I'll forget later, but if you want to come to the summit, please go to our website, KidneyX.org. You can sign up to attend the summit. There we're going to announce the winners. And I just want to say that we received 165 submissions from across the country and the world. Really, really interesting, fascinating ideas. And one of the things that we embedded in this process was every single submission had a patient reviewer look at it. In addition to that, before people submitted, we required them to talk to patients. And so we set up a system where they could talk to patients firsthand as they're developing their idea to get feedback on it, which is a different way of how healthcare works in general. Usually people develop a widget over in a corner and then they go ask people whether they want it or not. And so we want to flip the script on that a little bit. So it's really encouraging and exciting to sort of see the interest already in this. The second phase, as I mentioned, will sort of commence after the summit, and we're going to ask people to develop prototypes, and we'll select up to 3 prizes and award about $500,000 a piece for that portion of it. And I've been focusing on dialysis, but I just want to reemphasize that this is a prevention, diagnosis, treatment sort of frame here. We started with dialysis because there was a clear need there, but we're fully intending to look at how do we think about ways to slow progression? How do we think about new ways to identify patients who have kidney disease? You heard the stats earlier, right? About half of the people with advanced chronic kidney disease don't even know they have it, which is just insane. And thinking about other tools and other resources that are patient-centric that can help people navigate and the day-to-day life that goes along with CKD and renal failure. And I should also say that this is part of an effort across our department at HHS to really transform kidney care in every aspect. And the secretary in a speech last month laid out kind of 3 major goals in this initiative. The first is to find better ways to slow progression of CKD and kidney failure, because that's really where we should be. I mean, that's really where the highest return on investment is going to be at that point, and to sort of double our efforts there. But the second is to really improve ESRD treatment in general the way it is now, right? We don't provide necessarily, we don't have the payment incentives to provide the best care or to incentivize the best care, even the available approaches now to renal failure. And so, for us to rethink our payment schemes to improve patient quality of life and reduce costs is another goal. And the third is to address just the organ shortage in general, right? There are almost 100,000 people on the kidney waiting list right now. And so there's a severe organ shortage, and ways that we can address that shortage through living donation and deceased donation is another goal for us. So certainly the leaders at HHS are paying attention to this issue, and so I'm very I feel very privileged to work in this space where there's potential for doing that. And thank you very much, and thank you all for
Thank you so much. That was really, really interesting, and I think we're very excited here in the kidney community to see what comes out of KidneyX. So I know we're a little over time, but I wanted to see if anyone had any questions for any one of our panelists.
Good morning. I'm Taylor Ware with Congresswoman Adams' office. For any of the panelists, just wondering, for patients who might have complications with the medications for the transplant, are there research studies available to develop new medications as well, or is it mainly device focused?
That's a good question.
Sorry, could you repeat the question?
Yeah. So I know my father has been on dialysis for about 5 years now, and we're considering the transplant process. But he has a lot of complications already finding medications that kind of work with all of his other conditions. So I'm wondering if there are also efforts to improve the medications that are out there, or at least find alternatives for those who might have complications, finding ones that work.
So from a product development perspective, that's certainly on our radar. From a what's going on in a research perspective, I don't have an immediate answer, but I can find out and get back to you.
That would be awesome. Thank you.
Any other questions? Well, thank you again, everyone, for coming. This was a great